There is the Australian guidelines, which we've summarized. I find them a little bit narrow because they don't cover comorbidities. For straightforward cases, absolutely fine. I'm going to go through CADRA mainly because it provides 4 steps. If you suspect ADHD, take a detailed history covering all domains first, because ADHD is a disorder of exclusion. You can use any questionnaire. The question, particularly in adults, is really to support the diagnosis. They're not diagnostic by themselves as such. Often you'll see, particularly if someone's very depressed or very agitated, you may get false positives. They give you an idea about the individual's cognition, activity, reward sensitivity, their phenotype. That's what it helps you with. So I use ASRS, I use Wender, Utah, or I'll add Copeland Adult ADHD. Those 2 are sufficient. They give you a good picture, but I'll tell you what I find the most useful. Even before my appointment, if there's an assessment for ADHD, I will tell them to bring a family member to write down their story from childhood all the way to the current with their key complaints. I find this extremely useful for phenomenological reasons, but also vulnerabilities, presence of trauma, etc. Great for documentation, good evidence as to why I've gone down the path of ADHD treatment, collateral, etc. And that gives you a very good clue how descriptive the individual is, how much it's affecting them. And it's sometimes a really nice way of separating whether we're looking at a milder case, a significant case, how much of a medication adjustment is needed. So try it out. I find it extremely useful. I also find that story useful from the current evaluation. So I say, you've told me this is what we're going to focus on. I'm making a change. What we need to see is a percentage drop in this or this or this. Because symptoms don't just suddenly disappear. They'll drop. And each drop helps you with pattern recognition for learning as well later on. So you might prescribe a stimulant and you're specifically looking at, okay, can you tell me about your attention and concentration ability to focus? Has that affected your sleep? Has that worsened anxiety? So you're looking at tolerability and you're looking at the other side. So ASRS, you can use absolutely anything, but it's the clinical evaluation that's important. The next one, ensure that medical causes are ruled out. I really focus on sleep and lifestyle, particularly in younger adults and adolescents, because if they've come to you for treatment and their routine involves no goals, sometimes it can be part of the condition, absolutely, but if they don't have goals, what often tends to happen is they'll rely on the feeling, and you really want to shift towards the activity dimension. So this is where I will go halfway and then say we need to implement this, psychology, or whatever you think is appropriate, and then go with the latter half of the dose increase. Because I often say that what's going to happen is if there is no action, because remember that D2 ongoing activation is necessary. D1 I've given through the stimulant, but that only happens once or twice phasic. I can't give it because it changes from unexpected to expected, and that becomes a substance use type approach where I'm not feeling the same. D1 receptors sensitize very quickly. They're meant for reward learning only. So this is why I try to shift them into that activity dimension. And keep an eye on sleep. Sleep is so important in ADHD because it can really worsen prefrontal cortex functioning and evaluate potential contraindications. Do I do an ECG in everyone? No, not necessarily. I will take a family history of cardiac disease, sudden death in the family, and if they've got any risk factors themselves, I'll usually carry out lipids, etc. If they've got risk factors, I'll do an ECG. Otherwise, in my initial doses, I'll look out for pulse, blood pressure that is often documented at every single appointment, pre-baseline and then subsequently. And then the ADHD specific interview. This is your mental state examination, the history as you would do normally. You may consider a specialist referral and the kind of specialist referrals you might require. So this is very plain. This is CADRA guidelines as well, Australian: hearing, vision impairment, thyroid dysfunction, autoimmune thyroiditis. In females, I find 2 things: iron deficiency anemia, thyroid autoimmunity. If you're looking at TSH around 3.5 with thyroid autoimmunity, consider thyroxine. Thyroxine is essential to enhance dopamine receptor sensitivity. So you get a better response when you are prescribing that stimulant. You're not getting maximal impact. So sometimes doses just keep going up. It is very common, autoimmune thyroiditis specifically. So I carry out TPOAB, TGAB. Then you have hypoglycemia needs to be ruled out, but severe anemia, iron deficiency anemia. Now lead poisoning, obviously rarer. Sleep disorders really up there. Restless leg syndrome. In males, obstructive sleep apnea. In adolescents, children, adenoids and tonsils, sleep breathing disorders, really up there as well. So do look out for those ones. In males, I find obstructive sleep apnea almost always there.